Now, if you look at what the ADA says, first line therapy. Earlier, it was always first line therapy with metformin. Now, they also added the fact that we need to look at the presence of atherosclerotic cardiovascular disease or renal disease and consider using SGLT2 inhibitors or GLP-1 analogs as the first line therapy in the presence of either atherosclerotic cardiovascular disease or renal disease or presence of heart failure. In the presence of any of these three conditions, we could think of using either SGLT2 inhibitors when there is presence of heart failure or CKD, and GLP-1 analogs being the preferred choice in the presence of atherosclerotic cardiovascular disease. In the absence of these, the first line would be metformin. Then you would go on to the addition of other therapies depending on whether you would like to minimize hypoglycemia, when you would consider DPP-4 inhibitors or the SGLT2 inhibitors or the GLP-1 analogs. Whereas if your concern is to minimize the weight gain or cause weight reduction, then the choice would be between DPP-4 inhibitors, GLP-1 analogs and SGLT2 inhibitors. Now, and then the final other consideration that is always there is, if you're considering the cost as a hindrance factor for the management of diabetes, the consideration is towards the use of low-cost therapies like SUs or TZDs. The SUs still have a very important place. They are important even in patients who are started on SGLT2 inhibitors, who are on metformin, who still are not under control. Now, the other important factor that has come in this algorithm is that the fact that we could start with a dual therapy if the HbA1c is more than 1.5% higher than the target that we're aiming at. So if you're looking for a target of 7% and if you have an individual who has got a HbA1c of 8.5%, then the suggestion is to use dual therapy rather than monotherapy at that point of time. Then looking at the RSSDI-ESI clinical practice recommendation for the management of type 2 diabetes, again this was published in 2020 and it's going to be revised soon, and in this also we have a consideration to look at the age, the BMI, the ABCD rather. So where A stands for age, advancing age, you look at prefer certain medications over the others. BMI, increasing BMI, you look at certain medications. With the presence of CKD, you look at certain medications. With duration of diabetes, D is the duration of diabetes, E is established CVD, F is the finance, and G is the glycemic status, and H is the hypoglycemia concern. So all these A, B, C, D to H are incorporated in this wheel, where you can see clearly. This makes it very easy for people who are trying to decide which form of therapy is most suitable for their patients. They could do it very easily by looking at the wheel. As you can see in the A portion, you're looking at advancing age, you're looking at DPP-4 inhibitors as the first choice, AGIs, SGLT2 inhibitors, then so on and so forth, you have the other agent. Whereas with the increasing BMI, you're looking at the first choice being SGLT2 inhibitors or the GLP-1 analogs. With the presence of CKD, the first choice is SGLT2 inhibitors. With the presence of longer duration of diabetes, you have SGLT2 inhibitors, the DPP-4 inhibitors, and then the others coming in. And then again, looking at the established cardiovascular disease, again the two major classes of drugs like SGLT2 inhibitors and GLP-1 analogs fit in there. Now, when you're looking at finances, the SU comes in first, followed by insulin, followed by pioglitazone, followed by AGIs. So that is how we would look at it. So if you look at the SGLT2 inhibitors, we know that they work through the SGLT2 receptor present in the proximal convoluted tubule, which accounts for 90% of the reabsorption of glucose in the proximal tubule. So they lead to increased glucose excretion in the urine, leading to a glycemic reduction of 0.8 to 1%. And this can be combined with different classes of drugs. Now, if you look at the glycemic benefits I've just enumerated, they have several extra glycemic benefits like reduction in body weight, reduction in blood pressure, 2.9 kg reduction in body weight, and almost 5 millimeter reduction in blood pressure with 10 milligram dose of agent like dapagliflozin. They also have the benefit of causing less glycemic variability, providing a better glycemic legacy to our patients who are started on these agents early. And because of the glycemic durability that they have and less glycemic variability that occurs with the use of these drugs, they provide a good legacy for reducing the risk of complications. And they combine very well with metformin, and they have a synergistic action with metformin, with a combination causing a glycemic reduction of almost greater than 1% or close to 1.5 or 2%. Also with the combination of metformin with any of the SGLT2 inhibitors. Here we are seeing the combination of metformin with dapagliflozin. And what we see is that this initial combination works very well in terms of providing all these benefits and also providing a good cardiovascular outcome. Now, if you come to the DPP-4 inhibitors, as we can see here, the DPP-4 inhibitors are probably the most versatile agents, because what we see is that they act on many of the mechanisms. As you can see, the table shows a listing of all the mechanisms which are contributing towards the development of hyperglycemia, and DPP-4 inhibitors are influencing most of them. or influencing more than 50% of them. And while we see that some of them are addressing single defects like the SGLT2 inhibitors affecting only the kidney glucose loss, the AGI is working only on the GI tract, while some of the agents like metformin have multiple actions, and the DPP4 inhibitors are also very versatile, having multiple actions. We have a vast amount of experience with the use of these gliptins, and newer gliptins are also coming in, and this is a growing family of molecules which have a good glycemic reduction. They have a reduction in the HbA1c, FPG, postprandial glucose levels, and they also provide less variability with low risk of hypoglycemia and low weight gain. If you look at all the cardiovascular outcome trials with the gliptins, we see that with sitagliptin there was a very good cardiovascular outcome trial called the TCOS trial, which was a large number of patients, and it showed that sitagliptin is a very safe molecule, and the same outcome was seen even with the outcome trial of linagliptin, the Carbolina and the Carolina trial. Now coming to this very important class of drugs called the SUs, look towards the newer agents, the newer class of drugs. They are probably more safer. Glimepiride is one of those, and glycoside extended release is probably one of those in the newer or the modern sulfonylureas, which are associated with very low cardiovascular risk, as has been shown from various observational studies. This is one of them, observational studies, real world observational studies, or whether you look at a meta-analysis of all the other studies which have looked at the cardiovascular effect of SUs, and all these studies have shown that these molecules along with metformin work very well in terms of glycemic efficacy, which has a good durability of glycemic efficacy, and they do not cause any ischemic preconditioning as was seen with some of the molecules like glibenclamide. Molecules like glimepiride or glycoside do not cause this problem, and we could see this from the advanced trial with glycoside, or even the Carolina trial, which was a CVOT trial with Carolina comparison of glimepiride with linagliptin. And the Tosca IT trial was a comparison of SUs with pioglitazone, glimepiride with pioglitazone, and it showed that glimepiride was non-inferior to pioglitazone in terms of the cardiovascular effects. And the Carolina trial actually went on to show that this was a well-designed cardiovascular outcome trial which had an active comparator arm with linagliptin versus glimepiride. And what we could see is that there was a very clear non-inferiority of both the molecules, that is glimepiride worked as good as linagliptin, or linagliptin was as good as glimepiride in terms of the cardiovascular safety. From the cardiovascular safety point of view, these two molecules fared exactly similarly, and even when you looked at the 4-point MACE, you had similar effects. But there was small differences in terms of the risk for heart failure, which was more with linagliptin, while the risk of hypoglycemia was slightly more with glimepiride, but did not lead to any increased adverse cardiovascular outcomes. Time below range of less than 54 being less than 1%. And when you're looking at the preprandial and postprandial targets, type 2 diabetes, the target is more than 70% being in time in range, and for pregnancy we would like to